Welcome to the Sunstone Health Podcast, hosted by storyteller Justin Starbird and Josh Resnikoff, co-founder and CEO of TMA Precision Health. This podcast brings you inside the movement that's reshaping how we diagnose, treat, and care for patients who have spent years searching for answers. At the heart of it all, TMA's mission is to end the diagnostic odyssey through AI, data-driven insights, and expert human guidance. Here are your hosts, Josh Resnikoff and Justin Starbird.
Welcome back to the Sunstone Health Podcast. My name is Justin Starbird, and today I am joined by my co-host and founder of TMA Precision Health, Josh Resnikoff. Josh, great to see you. Great to have you on. This is the first of many, and we have so much to talk about.
It's great to be here. I'm excited to get this started.
Yeah, likewise. It's been a labor of love to get this far and to get this thing started. So awesome to have you on.
Yeah, it certainly is. It has taken a long time for us to build this, just sort of navigating COVID, the new administration, and let alone, having a kid with a rare syndrome at home, right? Like so many families. So it's, it feels really good to be here and to be able to talk about it and to be at a point where we can start to share the story.
Yeah, absolutely. I feel like it's one of those things that the world needs to know about, know that it's available. And, let's just dive in. You started TMA Precision Health a few years ago because of some stuff that was happening at home. Talk a little bit about, the journey. Introduce our audience to who you are and what you do.
Yeah. My story. So I'm a trained biomedical engineer. So I did both my undergraduate and graduate work in biomedical engineering. I had done my undergrad at UVM. I came down to Boston, got the opportunity to work for a woman named Sangeeta Bhatia at MIT. She taught me so much. I mean, it was such an incredible experience to be able to learn in her lab, one of the preeminent labs at MIT. And that really catapulted my science career in Boston and took me all the way to the Wyss Institute at Harvard Med. During the time I had two children. I now have three, but I had two children back then. And the second one is really where my story into rare disease kind of takes off. So his name's Shiloh. He was born very normal, really easy birth, popped right out actually. And he was like the happiest, healthiest little kid until he was about 18 months old. And then he started getting these insane fevers. So every month he would go, like in the time it would take me to go from the couch to the kitchen to make dinner, chicken nuggets, like something easy, he would go from 98.6 to 105. And if you have a kid, you know that anything over 103 starts to be ER level territory, let alone 105, where now you're in seizure level territory. And that 105 degree fever would stick around for 4 or 5 days. There was really nothing you could throw at it to bring his core temp down other than to put him into an ice bath, which I'll tell you firsthand experience, 2-year-olds do not really like to take ice baths. If that had just happened once, that would have been scary. But the challenge for us at the time was that it would happen every single month. It was a periodic. It happened recurring, right? So every 4 to 5 weeks, this would happen. We would see it happen. You could see it coming the day before. And we would just crash land into the ER. It always happened Friday night at 10 o'clock at night, right? Like it was never Tuesday during the day or something like that. We're always in the pediatric ER unit in Winchester, talking to a nurse who after a year of this says, we've seen everybody. So they're like, oh, you're here again, like we're going to help you out. But really spent years chasing answers to try to figure out what was going on with him, just to get a degree of sanity into our house so that, every 4 weeks, me or Shiloh's mom wasn't trying to figure out like who was going to have to take off 4 days of work to be home with this kid to make sure that he didn't have a seizure. And so we did that in the dark for about 2.5 years before we went through a couple of pediatricians and finally found one who said, hey, I think he's got one of these periodic fevers. And so me as an engineer, right? Like I'm a bench scientist at Harvard Med. We live in Boston. It's one of the best healthcare cities you could possibly hope to be in if you have a disease, or you would think so.
Right.
You know, I'm like, great, like eureka, we have this diagnosis. What do we do? What's the medicine? You know, how do we cure my kid? And the doctor literally looks at me in the face and says, there's nothing you can do. There might be about 500 kids in the States with this thing, but it's not terminal, so don't worry about it. And I almost went totally ballistic in this lady's office, because the idea that, you know, if you're a parent, your kid skins their knee and you want to like throw the kitchen sink at making them not feel bad, right? Like, your kid is crying and you will do anything in the world to make them feel good.
Right. You feel it, right? If they feel something, you feel it.
Oh my God. It's like when my kid has a bad day at school, you know, you're like, all right, buddy, like, let's work this out, you know? And so like the idea that my, you know, now 3.5, 4-year-old is going to have to like just deal with this thing, right? Where our whole family's just going to have to like swallow it. It just feels like, you got to be kidding me. There's like, this is, you know, you're talking 2018 in Boston. I was like, this cannot be the cutting edge of medicine.
Right.
Like, how is this it? But there wasn't a whole lot we could do. The specialist, the one specialist in Boston, was out of network. I didn't make enough money to pay for it out of pocket. We kind of knew all the nurses by first name at the ER, so we just kind of kept going through our process, you know. And so what was interesting, though, so sort of where this story takes off, is that the work we had been doing at Harvard had become a biotech. And I was working at the biotech, and the guy I was working with, his wife had Ehlers-Danlos syndrome. And he knew, which is a rare disease. It's a connective tissue disorder. And so he knew my story, because I'd have to be out of work for a few days. And they were so accommodating and so lovely to me, and just like helping me navigate this space. But as we started talking about it, he was like, you have to meet my wife, right? You're like, she has done so much work in trying to figure out how to tackle her own issues. Just meet her and talk to her. And I did. And I mean, they're like family friends now. We see them, you know, they've moved to Barcelona so that Lena could go get the care she needed, but we see them about once a year and stay together. It's been amazing. She brought me into her network and was like, hey, here are all the resources that I've gathered to help me manage and navigate my own rare disease. And from there, we just sort of birthed this mission, you know, like so many other parents or individuals who are affected by rare disease, that there's got to be a better way. And hey, we're pretty smart and accomplished people, and we have absolutely the determination and you know, like what more validation would you need than looking at your kid who's sick? Like, we're gonna go do something about this. And so that's really where the genesis of the story came, is this you know, a hardship that there wasn't a good solution for, and we had to go change something. And frankly, I am lucky. My kid is lucky, you know, like in the spectrum of rare diseases, the families I talk to now, we're on the good side. You know, my kid still lives a 98% normal life. Like, when he gets sick, he just gets as sick as possible. But the rest of the time he's out skateboarding and jumping out of trees. And it was enough to scare the crap out of me and make me want to do something, but not so debilitating that it took all of my energy. You know, I meet families. You're not
trying to keep them alive, right?
Yeah, exactly.
Channel that energy and look for a solution.
Yeah, there are families who are just trying to get through the day, right? And I'm at least able to. I mean, I've remarried since, right? The divorce rate for families with rare disease is like 95%. It's crazy, but my wife Michelle is amazing at helping. Like, Shai has so much support now in our house. We've obviously figured out the cycle and how to help stave it off. But yeah, we're lucky, and frankly, to be able to turn all of that energy and all that frustration on my side into something that we're helping families get better medicine, get to the other side. That feels amazing.
Yeah, absolutely. I mean, that idea is just so overwhelming for so many people that they're not sure where to turn. You know, having these resources at your disposal, how did you determine or decide or figure out, what the step was in order to start to systematize some of this stuff so that you could potentially turn it into a business?
Yeah, well,
I feel like that's a side story, but that's also kind of where the journey takes us.
yeah, I mean, look, the truth is, like all founders, right? It's not a straight line. There's a lot of zigging and zagging trying to figure it out. And anybody who tells you that like they had the idea at first and it's still the same thing they're doing now, they're lying to you. When Lena and I first got together, Dr. Lena Williamson, at first we were like, hey, we're just gonna go solve all rare disease, right? We can go find it all. We met amazing people. We had started to build technology. They had technology. We're like, we're just gonna go. There's 7,000 to 10,000 known rare diseases. We'll go get them all. That didn't work, right? So we had to really shape who we could help to start, right? Like how we could intervene. What was a meaningful intervention? What did results look like? And frankly, as we kept building what is now a part of the system and trying to deliver it back to the doctors and families that we work with, we were very open to the feedback that we were getting of like, hey, this part doesn't work for me, or this part doesn't make sense, or how do I do this thing? And so we'd go solve for it. And that has really allowed us to build what is truly the only end-to-end solution that starts by finding patients and delivers those treatment insights all the way back to that family locally. And I know we're going to get into that, so I don't want to jump the gun, but the truth is just a lot of trial and error, a lot of grit to like get through the times that weren't working, but really listening to families to what they needed to make sure that we were delivering something that was useful. Because the last thing I wanted to do was build something that I thought they needed or was just based on my own experience, but wasn't actually applicable to most people.
Yeah. How did you determine what was, that case? Meaning, when you would attempt to, go solve for something, you're seeing it through your eyes and what worked for you. But, to your point, it didn't apply to all circumstances. And, you have had the opportunity to speak with some incredible families that you haven't necessarily been able to help yet. How do you balance those two?
So that was a big question. And so the truth is that when we started working in Medellin, Colombia, we got to work with amazing doctors, amazing families. The health system down there is fantastic. I think it's ranked 32nd in the world. But the challenge that we had with some of our North American, let alone United States counterparts, is that they didn't have the faith that their Colombian colleagues could appropriately diagnose rare diseases. And you can read into the lines of that however you want. But it was a forcing function for us to go off and focus on diseases that no one could argue with us about. And frankly, that's how we really were able to focus on pediatric genetic epilepsy as a starting point, because nobody can argue about a kid having a seizure, right? And it was a really maturing moment for us as a company because, if you know anything about startups, right, like there's a very classic, you start wide, right? Like I'm going to go solve all the problems. You get really narrow. Hey, I got really good at this one thing. And then you can go wide again because you have a basis to build off of. And
Yeah.
this was this part of the growth for us, right? We were going to solve all rare diseases. Well, that's not going to work. All right, well, we're going to solve, or at least we're going to really get good at helping families with kids with epilepsy, a genetic basis for epilepsy. We're going to learn how to find a genetic basis for that. We're going to learn how to infer from all sorts of different symptoms and claims that there's a genetic basis for that. And it's not, a one-off febrile seizure, or it's not a viral issue. It's not related to some sort of mechanical trauma like a car accident. And we did that. We spent years getting excellent at that and putting together the system to help families get the reports they needed so that they could get a local diagnosis and really improve their care path locally. And by doing that, it gave us the system, the product, the service to be able to come back up here to the States and start providing that commercially to employers to help their families. And we've already been able to build on that. So we're now offering a system to go address autism spectrum disorder. We're looking at systems to address pharmacogenomic issues. And what we've really learned is that we have a much bigger opportunity to grow again, very, very wide because of the infrastructure, because of the technology that we've built to go off and find these kids and connect them to the right services.
So talk a little bit about that, because I feel like we skip a little bit ahead there, where you're identifying families to potentially work with and rare diseases to help solve for. How did you decide, how to go about helping those families, though? Instead of going right to the family and saying, hey, it's a one-to-one, you've decided to go to the employers. How did you come to that? How does that work? What does that business model look like?
Yeah. So, and this is something that is very unique to us. There are a lot of people who sell point solutions to employers, but there's not a lot of people who sell a package of point solutions or an infrastructure, a technology infrastructure to employers. But look, I'm a engineer, like through and through, right? Like I always have been, and I'm a trained engineer, and so I'm very much a systems guy. When we did our commercial analysis of how the health delivery works, right? Like how do you actually get results to the people who need the results to make decisions? How do you get it's not just results, right? If you just run an assay, you run a test, and you get a technical form on the back end of that, and you hand that back to the doctor, there's a good chance the doctor has no idea what to do with that information. That's not because they're not smart people. They've just never been trained in the specific discipline that you're talking about, right? Like you can't give a cardiologist an MRI of a brain and expect them to know what to do with it, right? So you can't just hand an untrained or an unfamiliar doctor like a whole pile of genetics and be like, yeah, you're good to go, right? So you have to provide insights for how to actually act on those outcomes for people. So that was a big part. So that's part of solving for how to actually get the care back into the hands of people who can do something with it. But then as we're looking at the space, one thing, I guess it's really more of a moral issue for me, is I didn't want to go back and charge the families any more money, right? These are families who are already under such a huge duress, probably under a huge financial constraint as well, because you got to get your kid from A to B, you got to take time off of work, right? Like mom or dad has to go miss work. Like it's challenging enough for families. There are companies here in America who will charge families $150,000 to help them navigate a rare disease pathway. I think that is such crap. Like, I just think that is so repugnant from a business standpoint that you are effectively preying on people who are looking for answers and are so willing to like remortgage their house if you can give them a shred of hope. So we didn't want to do that. I didn't want to do that. Then the obviously next stop is what we call providers, right? The hospital systems. Most hospital systems, they operate at about like a 1 to maybe 3% profit margin on a good year. They don't have a lot of money, and the politics of getting involved in the hospital system can be challenging, depending on which system you're with. So, we talk to a lot of providers. We want to work with a lot of providers, but it didn't necessarily seem like the best pot of cash to go after, right, from a commercial perspective. And then really when you look at it, right, like who are the people with the money in the system? That's the insurance. Okay, well, so insurance controls, they can have the pocketbook. They control the payment structure for how anything gets done. And the dirty truth of all of healthcare, at least here in America, is that if you want to make something that's going to have scale for patients, you have to make it financially viable for insurance companies, because that's their motivation. Yeah. So really, there's a very interesting part of TMA where I work for families. My mission is to help families get healthier, help their kids get healthier. As a company, we really end up working for insurance companies, and the product that we have actually built for insurance companies is really a financial mechanism that lets them do the right thing for patients, right? So it's a way for them to save money by not paying for a whole bunch of unnecessary things. Mm-hmm. It ultimately is a forcing function for them to do the right thing for patients. And that's kind of like our big secret unlock on the back end. Yeah. And so then in insurance, there's really two flavors of insurance. There's fully commercial and insured. So that's your United Health, your Aetnas. And then you have here in America what are called self-funded employers. And so they actually end up being the ones to carry the financial risk on their own employees. They still might end up using a Blue Cross or an Optum to do the claims processing. We're going to get down like a wonky rabbit hole if I go too far here. But the point is, about 2/3 of Americans get their health insurance directly from their employer, whether they know it or not. And what's great for us as a company is that fully insured insurance, they're the ones with the terrible reputation of like only looking at human lives as dollars and cents, right? And like how much, they're the deny the claim so they don't have to pay out.
Right.
You get to the employers, they have a vested interest in keeping their employees and their employee families healthy, even if it's just as selfish as we don't want mom and dad to miss work, right? But like for a fully commercial insurance plan, you talk about timelines where they have turnover every 2 years, right? Like they don't even think from an actuarial perspective beyond 24 months for how to interface with this patient. We have customers who have employees who've been with those companies for 17 years because of how good the health insurance plan is, right? So they're always looking for ways to go off and do better by their members. And that's really where we can come in and provide them a real value add.
So you work directly with the businesses to provide their employees with the best opportunities to, have services, but also to find answers.
Yeah, that's exactly right. So we focus specifically on that self-funded employer health plan market, right? And that can be everybody. So in America, the financial corner, when you hit about 100 employees, it really starts to make a dollars and cents value for you to carry the financial risk instead of paying a premium to a third party to carry that financial risk for you.
Sure.
We focus on companies that are what are called the mid-large sector. So that's companies with 1 to 10,000 employees. That's really our sweet spot right now. Bigger than that, and it's a lot more infrastructure, and frankly, a lot of those big guys have their own infrastructure. And smaller than that, it can be a little bit hard from just a per capita standpoint to get involved. So that mid-large space is really good for us.
Yeah. How do you keep, you and I have talked offline a little bit about this, but how do you, ensure that privacy is maintained, and making sure that the employer doesn't necessarily have judgment against, a family that's ill?
Yeah, it's actually one of the first questions we get from most people who are evaluating the plan. So what you're referring to is GINA, which is the Genetic Non-Discrimination Act. So we worked really hard to make sure that we want everybody to be able to say yes, right? So it's the way our commercial model works, where we don't charge employers any upfront. We only get paid when we deliver results, right? So that's an easy, no risk way for them to use our service. Same thing for protecting them from GINA, right? Employers, unions, they don't want to know their employees' business. They just want to make sure that they're providing opportunities for those employees to get the best healthcare possible.
Yeah.
So we work for companies, for employers. We contract with them to underwrite the services that we're going to go do. But after we've identified anonymously from claims data from the employer, we then break our relationship or our communication with the employer, and we go off and communicate directly with the patient. So we go recruit that patient, and then we effectively contract directly with that patient. So we sign a consent form with them in terms of service, and it does a lot for us. Now we're working on behalf of the patient, and there's a whole lot of stuff that we can go do on their behalf, and we never have to we never have to. We legally can't. We do not ever tell the employer what's going on with them. So everything that happens with the patient remains between, it's their information. We make sure that we provide all the data back to them. They own all their own data. And it's really a conversation for them to have with their local care team. It has nothing to do with HR, their CEO, anything like that.
Yeah. Yeah, that's incredible. So, that's a good segue, though, talking about the work that you actually do for the client, and the client being the patient that is now, unfortunately afflicted by, a rare disease. What does that process look like, and what do you actually deliver?
Great question. So, all right. So the punchline here, and I'll skip to the end and then I'll get into the details, is that for a kid with a genetic epilepsy, their path, it's called the diagnostic odyssey, and it's called an odyssey for a reason. All right. So from first seizure and first ER visit to the time that you get on a care path that will work for you, on average, for a kid with a rare disease, is 7 years in America. All right. And that's because you are getting bounced from specialist to specialist, from referral to referral. my son is 10 years old. We're still on our diagnostic odyssey. Like, we have this PFAPA diagnosis, but now he's got a new hip issue, right? And he's got this new rash. And so we're getting bounced around through Boston Children's. So I very much know this part of the side of the journey. Almost all of that, for especially a kid with epilepsy, or especially someone with a known genetic basis for their disease, is because they have to go through, because commercial insurance, I don't want to sound like a conspiracy theorist, but because commercial insurance has so much influence over how things get paid for, they only want to pay for the cheapest possible intervention to start, right? And once you've exhausted the cheap one, you can go to the next most expensive one, and then you can go to the next most expensive one. And so that creates basically the most circuitous route for a patient to get to the most comprehensive test that they could do. The mathematical challenge, like, again, as an engineer, is that for a company, you're going to pay for that 7-year process when you could have just skipped right to the end and paid a little bit more money up front, but saved all the money in between. And that's the forcing function that we do. So when we flag a patient that has a very high degree of confidence based on all of the models that we build, all the work that we've done, the AI that we employ, that patient has a genetic basis for epilepsy, we go back and we talk to the HR team at the employer. We explain why we believe what we do, and we get a green light from them to move forward. Mm-hmm. The minute that happens, we go recruit that patient and their family on. We do what's called trio whole genome sequencing, which there is no reimbursement code for today. We bundle all that into a genetic with a genetic counselor. We get them sequenced and reviewed. They get the whole thing reviewed by a disease expert. So if that kid has specifically SCN1A epilepsy versus TSC, we have that case reviewed by someone who has a discipline in that. And then we deliver what's called doctor-to-doctor guidance back to that local care team. And that 7-year journey that kid would normally have to take, we can do all of that in 12 weeks. All right. And so the difference, obviously, is massive for a family who wants to get to the information.
Yeah.
But the cost structure of that for the employer is where they get to save a lot of money just by doing the right thing. And so it's really a way, like, we've really worked hard to make sure that everybody along the path gets to say yes. The doctors love it. The local doctors love it because they're getting expertise and they don't have to lose their patient, right? That kid or that family, if they're in South Texas, they don't have to get on a plane to go up to Houston to go see a specialist. Their local doctor is just going to get that level of specialty brought to them. So it's, for us, it's the tech we've built both identifies the right patients, but also just collapses all of the right moments and forces them to work together in an efficient way that we all want our current healthcare system to do. It just does not right now.
So how have you had success? So I got a couple of things here to follow up on that, because, the model that you've created where it gives everybody the opportunity to say yes is clearly an anomaly in healthcare right now. How have you been able to, make sure everybody sort of sees it from the right way, and they're, gives them the opportunity to do the right thing? I guess it's sort of a money thing too, no?
So I'll start at the bottom. So the money thing is like when I sit down, so there's two sides to the money thing. When I sit down and explain to the company who's going to underwrite the costs, right, and we just run the math out with them, because they contract with us directly, we're almost more of a supplemental benefit in this than like a we don't go through reimbursement, right? So anything that we do is a direct contract. Sometimes it can get called a quality improvement service. It's just an accounting term. But the flat fee that we charge a company is already so under what they would pay through individual reimbursements for any part of this process that they're already saving money, right? Significant money. The second part is that by getting a family to a place where they know what's going on, there are studies out there by the Undiagnosed Disease Network, by Every Life, where they show that you can have a 95% reduction in a family's medical cost expense just by getting them to a place where they understand what's going on. And I can attest to that from my own journey, where the minute we knew what was happening with Shiloh, we wouldn't go to the ER every month because we were like, oh, we're still having the same exact symptoms and the same exact presentation and the same challenges, but we know that the ER can't do anything for us anymore, right? So we know that we have this other path that we have to go take. So already our health bill has gone down. So other families get to do the same thing, right? And if we can offset one ER visit for a family with epilepsy, like we've already paid for ourselves as far as the employer plan is concerned. Okay.
Sure.
Sorry, what was the second part of your question, or the first part, really?
Really, what are the challenges left? For more people to take advantage of this.
Yeah. So part of your thing was like, how do we make it so easy, or what is the opportunity to say yes? Everything is opt-in for us. Okay. So if you want to come work with us, we ask you to opt in to share de-identified records with us. When the doctor, your PCP, says, hey, there's a company who wants to help you, you get to say yes. No one is telling you that you have to work with us. And because I make sure that you own all your own data, if you're like, hey, I used your service and I don't want to know about anything else in the future, thank you very much, right? Like good for you. You have the right to be forgotten. It's a very important thing. But because of that, and I think because I understand what these families are going through, we've been able to get to a place where we have a 90% opt-in rate from families that we offer the service to. And there are people there for like religious reasons, or they're just exhausted by the process that they've been through, that they don't want to do it. And that's fine. That's totally fine. But almost all of the families that we offer our services to say yes because they are exhausted by the crappy situation that they're in, or the crappy solutions that their doctor has tried to offer them. Or they feel like they've hit the end of the road with whatever their insurance will pay for. So it's a way for the employer to provide an additional layer to their ability to get to a place where they get some sort of control over their life, right? Emotional or actual health control over their life. What's interesting is that we know just through the general market that both Aetna and Optum have tried to do similar things, and their opt-in rate, I think it's in the single digits. It might even be less than 1%. And, I'm not here to necessarily talk a whole lot of smack against Optum, but I think it's very challenging when your health insurance company calls you and says, hey, we think you might have a genetic disease. We'd like to sequence you and find out. Like, no one says yes to that. But we've been able to build trust as a third party with families who've used us, with other doctors, right? Like people there. We're obviously mission driven, right? And I think that trust really helps us get this over the line for people who might otherwise be on the fence.
Yeah. It's incredible what you've been able to accomplish so far. I mean, in really such a relatively short period of time. I mean, I know that at the end of the day, when you're thinking about it from the personal standpoint, a day can feel like a year going through a circumstance like this. But, thinking about 2017, 2018, and here we are in 2025, knowing that that's 7-8 years versus, others who are just beginning this and just can feel absolutely hopeless, and know that now there's a potential solution out there to help them get to a spot where, there are answers and an opportunity for proper care.
Yeah, it's there are a lot of really good efforts out there to help families with rare disease. I have met so many amazing patient advocacy groups, right, who are focused on their own area of challenges. There's great work, a lot of really great nonprofit work happening at places like The Broad, at places like To Cure a Rose down in Austin, La Jolla Lab. I mean, there's just so many people I could name. I think that all of them are doing fantastic work. The I have had with most of those groups is that they end up being very reactive. They are still waiting for patients to find them. And the way that we solve that problem is to build this tech that goes finds those patients, right? Just where they are. And for us, there's an obvious commercial component to that, right? Like if you can enrich the top of your funnel, you're going to have a better job converting those patients into customers, or converting the patients into users and being able to use those users to invoice your customers, right? When you actually deliver results. But even more importantly for me, it's a way for us to fast track our ability to help people, because I am at heart a very impatient person, and being able to help, one family a month or one family a year, like it's good work, but it's not enough for me. So we do it this way.
Yeah. Well, Josh, this is just the beginning of our journey. You and I are going to dive into every one of these topics, probably in their own episode, because they deserve it, just to be able to go deeper, wider, and where you are an engineer at heart, there are, some finer details that a lot of people will appreciate. So, I'm really looking forward to this show and sharing that with our audience.
Yeah, I'm excited to be able to share the story, get into some specific testimonials from people, bring on some experts who can, who people I really admire for the work that they do and the way that they try to change the system. I'm really excited to be here. It's going to be fun.
Yeah. And we've got some special announcements coming up. I mean, there's a lot coming. This is going to be great.
It's going to be cool. It's going to be cool.
Well, on behalf of my co-host today, Josh Resnikoff, the founder and co-founder of TMA Precision Health, you've been listening to the Sunstone Health Podcast. Until next time.
Great. Thanks, Justin.